Hello, everyone, and welcome to our podcast. I am Dorina Esendagli, and I work as an adult pulmonologist at Başkent University in Ankara, Turkey. I am a part of the editorial board of Monograph as the early career member representative. We are here today to discuss about the recently published monograph, Lung Transplantation, and I'm so glad to have here today the two guest editors. Michael Perch is an associate professor of clinical medicine at the Department of Clinical Medicine at the University of Copenhagen in Denmark. He has got many leadership roles, and I will mention some of them. He is the director of the Danish Lung Transplantation Program. He is the associate medical director of the International Thoracic Organ Transplant Registry, and he's also the chair of the transplantation group of the ERS. Michael's expertise extends to various facets of lung transplantation, including primary graft dysfunction, chronic lung allograft dysfunction, infections, immunosuppression, and he's also involved in the interventional pulmonology field. We have also here Federica Meloni. She is Associate Professor of Respiratory Medicine at the University of Padova, Italy, and she has worked as a transplant physician for over 20 years. She is mainly dealing with lung transplantation candidacy and post-transplant follow-up, and she has been involved in many clinical and translational researches related on chronic lung allograft dysfunction, and she has also explored the mechanisms of action for the extracorporeal autopheresis. Federica has served as an ERS officer for a long period of time, and she is actually the head of Assembly 8 in ERS, which is thoracic surgery and lung transplantation. Welcome to both of you.
Hi, Dorina.
Thank you very much, Dorina.
I have to say that this podcast is a special one because I have to mention that I am the early career member representative for Assembly 8. So I have been working with the two guest editors during my mandate, and I want to thank them especially for having involved many early career members as co-authors in the monograph. Thank you very much for your support. So to start our conversation, I would like to ask you first, how did you get involved in lung transplantation? How did your journey start? So Michael, do you want to start?
Sure. Actually, it was very much a coincidence. I applied for a position which I didn't know very much about. My main interest was the interventional part, but it was also to explore transplantation. And for some reason, I've just been there ever since.
And Federica, do you want to mention your journey? How did it start?
Yeah, I started because I was very interested in immunology and in lung disease as well. So I found that this combination of lung transplantation was the best field in the world to address immunological issues in the field of pneumology. I was excited by this field and I could never finish involving in this project. So I think it's just like an addiction in my case.
Well, thank you for sharing your experiences. But I think that lung transplantation actually is a very specialized area and only a few people are involved. You know that in our assembly also we have a few members as well because this is a very challenging area and is not very well known among pulmonologists who are outside the transplant centers. However, we know that the patient referrals for lung transplantation should be timely and they should begin in centers that maybe are not specialized centers. So can you please say to us if this monograph on lung transplantation is for a broad range of pulmonologists or is this specific for especially health workers who are working in specialized centers for lung transplantation?
Dorina, I think this monograph is for both specialized healthcare workers, pulmonologists, but also for pulmonologists who are working in broader respiratory medicine to sort of get a feel of when is lung transplantation a possibility, also specifically for specific diseases, and when is it relevant to think about referring patients for evaluation at a specialized transplant center?
Yeah, I agree. We wanted to design this monograph when we spoke about it the first time in order to provide information also to general pneumologists, in order to give them information for the timely referral of patients for lung transplantation, because we know that still we have in a high percentage of cases late referral of patients, and we cannot examine them in a proper way before transplantation, and sometimes they failed to reach the goal of being transplanted. So it's very important that all this information are provided to the general pulmonologist in the right way.
There's a chapter describing indication and patient selection and timing of referral for lung transplantation, which has been written by younger members of the ERS and also senior members with great experience.
Yes, I totally agree that this monograph actually is intending for a broad range of pulmonologists. And it is so well organized because it starts with, first of all, the care that should be done before lung transplantation, optimal care. And there are different chapters for different diseases. And I think that this information would be especially interesting for the general pulmonologist, and then go on with the lung transplantation. The lung transplantation monograph, the previous one, was in 2009. So we have like 15 years that we have the updated version. So what do you think are the new insights that the new edition brings?
Oh, I think there are many. The disease spectrum has changed a bit over time. For example, cystic fibrosis is a less common indication for transplantation, while the ILDs are becoming more common indications with an older patient population and the challenges they might have. Also, during this 15-year period, procedures like EVLP, ex vivo lung perfusion, has evolved and is being used to evaluate donor lungs. In some countries, also the use of donation after circulatory death is being used or is being introduced again. So on the donor side and on the recipient side, a lot of things have evolved since 2009.
Or maybe the management of some immunological complication. We have new guidelines for the diagnosis of some complications, in particular chronic lung graft dysfunction, and most recently antibody-mediated rejection. So we are improving, and we have more weapons to try to counteract these complications. So there has been a substantial evolution of the post-transplant management.
Yes, we do see that the survival of patients has increased within years. So I think that would be a very good indicator that many things have happened, and the research is going so fast, especially in lung transplantation, that maybe we'll have the other edition even in a very short period of time, let's hope. I wanted also to talk about the availability of donors. As you told us, actually, it's important to optimize, let's say, the donor pool and to manage the allocation in an appropriate way. So what might be the steps that we can take to increase this donor pool, which is really very challenging in many centers?
I think if you look at the beginning of the lung transplant history, there was a very conservative approach to who could be donors for transplantation. And due to many reasons, that has had to be challenged due to the lack of sufficient donors when comparing to the need for transplantation. The number of marginal donors, marginal due to either age or concomitant disease or smoking history, is increasing, especially in Europe. And it seems that the results are fairly similar. But to do that, we have needed the ability to evaluate these lungs before transplantation, and there EVLP has been a major help.
It's a work in progress. We should always push people from the ICU in order to improve the preservation of the donors, in particular for the lung, because it's a very tricky organ to preserve in a multi-organ donor. And on the other side, there has been this improvement with the utilization of DCD and with the possibility to evaluate and in some cases recondition the lung with the EVLP.
Maybe it's good to mention that when there is a solid organ donor, it's only approximately 25 to 30% who donate the lungs for transplantation, meaning that lungs are probably the organ being utilized the least when there's solid organ transplantation, which of course also is a challenge for the field.
Yes, of course, I agree that we should also raise awareness to all the doctors that maybe are not pulmonologists, but who have an end stage or a diseased patient who is suitable for the donation, not to think about only liver or kidney, but also to preserve lungs so that they can be a good donor. And I think that with the improvement of care and with better results nowadays, we are also more courageous to use, as you told us, more marginal donors because we need the donors. They are crucial. But let's say that we found the donor and we did the surgery, which is a very massive surgery, but we could do it. And then is the post-transplant care. That is also very challenging in the lung transplantation field. And with the rising number of lung transplantations worldwide, we know that all the pulmonologists actually should know some knowledge about this post-transplant care because it's not only something that will be done in transplant centers maybe in the future when the patient number increases and the survival rates also increase as well. So for the post-transplant long-term care, what should we keep in mind for the possible complications?
I think there are many different acronyms evolving at the moment. So we have ALAD and CLAD and AMR, and I can continue. But if you look at this overall, there is often a reason that something happens. So we always measure lung function as the effect parameter after transplantation. And we are quite concerned if there is a decline in lung function. This might be due to some acute event like respiratory infection, but could also be a sign of something more chronic, leading to chronic rejection. There are many risk factors for developing chronic rejection. And of course, immunosuppression levels and everything is crucial, but maybe viral respiratory infections are the major driver in acute decline in lung function. And I think that's an area where we can improve.
Yeah, I agree that we are creating a lot of acronym and we are complicating the diagnostic part of this complication after lung transplantation. So it's not so easy for the general respiratory physician to go deeply into the classification of this post-transplant complication. But you are really right that the basic is to follow up how is the graft function. And in any case that we see a drop in lung function, then we can start with the subclassification and the algorithm for the diagnostic follow-up of this complication. And the right management of basic immunosuppression, as well as the management of infectious complication, should be, with the usefulness of this monography, known by all physicians who want to go deeply into this field.
Yeah, so if I could just add a comment. So transplanted patients can have the same diseases as everybody else and should be evaluated, like everybody else. And of course, if there is concern that this is specifically related to the graft or something which is without the knowledge of the handling physicians, then I think most transplant centers would be more than happy to be approached that their patient is admitted somewhere and there's uncertainty what the cause of illness is.
Maybe the main difference here is that the spectrum of infections is broader. And I think that the key here is continuous follow-up. So it's not like, well, our work is done and you can go home, but you have to follow up the infection, see again if the spirometry is going down or not. And the organ rejection, especially for lung, is an important matter because we know that at the end, most of the patients will develop a chronic rejection. So what can you say about the therapies and the developments that we have had in the immunosuppressive treatment? How are they affecting outcomes? Do we have new approaches in order to decrease the risk for organ rejection?
We had a lot of improvement in the last year, mainly in the diagnostic approach, because we came up with a new classification in the diagnosis from the pathological point of view, but we also had new tools, for example, molecular or less invasive techniques like cell-free DNA, which were not available 15 years ago when we wrote the previous monography. So now we also forecast that we will have in the next year more and more tools to make a less invasive diagnostic approach to this patient for the immunological complication. However, some road has to be again to be made, because we are still struggling and fighting against chronic rejection for our patient, which is the main limiting factor for the long-term survival. So we are still working on it, and we do not have in this field much of an improvement, even if some studies are now ongoing on new treatment strategies.
Where I see the evolvement is that from going from standard triple immunosuppressive regimens, this is now being more personalized to depending on different types of problems in the patient. Could be kidney problems, could be AMR, could be other things. And the combination of drugs is starting to change, and it's being maybe somewhat more complicated.
Also coming from other settings like hematology, rheumatology, or other solid organ transplant settings. So we have some more available drugs, but anyway, the scenario is getting more complicated.
Oh, yeah.
It is quite challenging, really. What you do is quite difficult. But when I read the Monograph chapter that was written by the patient perspective, I think the satisfaction comes from there when the patient feels good at the end and has a better quality of life at the end. So it's worth it for those people. So to conclude, I have my last question. In your view, what do you think that the future of lung transplantation hold? And is there any exciting breakthrough or an emerging trend that you believe will shape the field in the future?
Well, I think there are a lot of things going on. And we have seen that in solid organ transplantation in general. I mean, just recently we have seen quite impressive developments within xenotransplantation. But also on a smaller scale, the use of stem cells, mitochondrial transplantation, other new approaches to transplantation is definitely evolving.
The future is bright, I think.
Yes, definitely.
Yeah, I think it's difficult to forecast because everything is evolving very fast. However, surely in the field of cell treatment, cell therapies, immunoregulatory strategies, organ engineering, maybe more in the future than these first things that I listed. So I think it will be exciting in the next decade.
Yes, Federica, transplantation is always exciting, but it will be even more in the future.
Always exciting, even more exciting. Yes, I agree.
I really want to thank both of you for the valuable information that you have shared today. And I want to invite all the listeners of this podcast to read all the chapters of the monograph if they want to find even more detailed information. Thank you for listening to us, and goodbye.
Goodbye. Thank you, Dorina and Federica.
Goodbye. Thank you.